So I think one of the things that's just very exciting about this review is the topic and fetal cardiac interventions. In my mind, this is the new frontier. We've gone through so much change in the last 40 years of cardiac surgery, things like the heart-lung machine that didn't even exist back in the day. And now we have this new frontier where we can provide interventions while the baby is still in the mom's womb. My name is Elizabeth Stevens. I'm a pediatric and congenital cardiac surgeon at Mayo Clinic.
Hi, my name is Yasser Qureshi. I'm a director of fetal cardiology at Mayo Clinic.
And we're here to discuss an exciting article entitled Towards Eliminating Perinatal Comfort Care for Prenatally Diagnosed Severe Congenital Heart Defects of Vision. This is going to appear in the May edition of Mayo Clinic Proceedings. This is applicable to a relatively small set of patients. So many babies are well compensated and can grow and have all the nutrients they need when they're in the womb. But there is a subset in which the congenital heart disease that they have progresses. It gets more severe during the pregnancy, and that makes the outcomes not as good and the interventions more difficult with more complications. And so this opportunity to either correct this progression or stay this correction is, I think, something that's going to really revolutionize our ability to take care of congenital heart disease patients.
One of the exciting lesions where a fetal intervention can be used is hypoplastic left heart syndrome, where you could potentially identify a subset where a fetal intervention can actually change the outcome prevent the development of hypoplastic left heart syndrome. And this main subset of patients is for those who start off with aortic valve stenosis, and then the left ventricle starts dilating and become very dysfunctional. And then you start noticing reversal of flow at the aortic arch level. If you intervene at that time, before the left ventricle starts becoming small, then you can potentially promote the growth of the left heart, specifically left ventricle, and even prevent the development of hypoplastic left heart syndrome. The intervention in this setting would be a balloon valvuloplasty of the aortic valve with the needle introduced through the mother percutaneously through the uterus and down into the baby's heart and dilating the aortic valve. If in some situations, you can potentially prevent the development of hypoplastic left heart syndrome and can even go to a biventricular repair in those settings.
There are also opportunities for fetal cardiac interventions that have not been implemented in clinical practice. And one of those relates to Epstein anomaly. We at Mayo have a long history of taking care of patients with Epstein anomaly, and there's a wide range of the severity of the disease. But some patients in utero have such massive right hearts, so such severe cardiomegaly, that the lungs are compressed, almost like a congenital diaphragmatic hernia patient where you've got lots of domain and so the lungs don't have space. In these patients, there are a number of complications, including that ability of the lungs to then even support the baby once they're born, and arrhythmias. So one of the potential opportunities would be to, while the baby's still in the womb, to do something to decrease the size of the right atrium in particular. So again, this is, in this anomaly, the tricuspid regurgitation causes the right atrium to get quite enlarged, and it can actually basically fill the whole chest. So if you could go in and either placate or prevent some of that tricuspid regurgitation while the baby is still in utero, you could offer hope and to these patients who otherwise would not be able to survive simply because their lungs were not allowed the opportunity to grow. So that's something that over time, hopefully we'll have some more experience in and be able to offer.
When the parents come here for fetal intervention to Mayo Clinic, they will meet a comprehensive team of multiple specialties, including maternal fetal medicine, specialists, the neonatologist, pediatric cardiologist, cardiac surgeons, anesthesia, both for the mom and the baby. And all of these teams work collaboratively because in these interventions, the risk is not only to the baby, but also to the mother, and that needs to be taken care of as well. So with these multiple specialties, we got a team of specialists who are taking care of the mom, and the other team that is actually addressing the care of the baby for that purpose. After the fact, the baby will still potentially require some sort of surgery. So the cardiac surgeons are always involved. There's always a risk of preterm labor. There's a risk for mortality of the fetus, as well as there are risks for the mother from the anesthesia as well.
In summary, this is an exciting time when we have innovations that are allowing us to provide better and better care for congenital heart disease patients. We hope that you enjoyed this article in the May edition of the Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.